Hello, my name is Akshi Batra and I'm here to discuss rituximab as a novel therapeutic agent for treatment of refractory heparin-induced thrombocytopenia. As we all know, HIT is a prothrombotic process that occurs because of formation of anti-heparin antibody secondary to heparin exposure, which leads to platelet activation causing formation of thrombin. So this case begins with a 57-year-old male who presented with chest pain after 1 day of being discharged for STEMI, which needed stent placement. In ED, his EKG showed new STEMI, so he was taken for coronary intervention. During intervention, stent was found to be occluded, needing ballooning. After being transferred to cardiac floor, within hours he developed new chest pain, for which he needed second coronary intervention and was found to have repeat stent occlusion. Given the repeated in-stent thrombosis and his platelet count decreasing from 224,000 to 50,000 within 5 days of heparin exposure, concern of HIT was raised. 40 score was calculated at 7, indicating high risk of HIT. So heparin was stopped and bivalirudin was started on day 1 of admission, as we can see from the chart. However, patient developed again instant thrombosis on day 3 while on bivalirudin. Because of failure of therapy with bivalirudin, the patient was transitioned to ergatroban, given better institutional protocol for monitoring as well. While on ergatroban, on day 13, as we can see from the graph, patient developed left ventricular thrombus. We can also see that in figure 3 on echocardiogram. And he also developed bilateral pulmonary embolism as seen in the CT scan in the figure. He also developed DIC, needing ICU transfer while on ergatroban drip. In ICU, he was given solumetrol and IVIG with transient increase in platelets. However, again developed upper extremity DVT. At this time, we thought of longer trial of dexamethasone and IVIG, which again led to short-lasting improvement in platelet. On day 27, patient developed DIC again. So, we thought about giving him rituximab in anticipation of blocking the anti-heparin PF4 antibodies. After rituximab, we saw that the patient had stable increase in platelet. He was also started on steroids with a plan to do a taper for 4 to 6 weeks on day 28. Patient's platelet increased to 231,000 on day 34 and he was discharged on fondaparinux. On clinic follow-up, his platelets increased to baseline by day 53 and anti-PF4 antibodies were undetectable by day 141. Coming next to discussion, on literature review, we found a case in 2013 where rituximab was trialed in refractory HIT, but its efficacy couldn't be evaluated because the patient's course was complicated by infection and gangrenous limb. So, this is the first reported case of refractory HIT resistant to multiple anticoagulations, steroids, IVIG, that ultimately responded to rituximab. Given the rarity of HIT overall, there are no management guidelines for treatment of refractory disease, and such cases remain a challenging clinical scenario. So more work is needed to understand if all cases of refractory HIT have an autoimmune component, and we need to further explore the role of rituximab in management of refractory HIT. These are the references. Thank you so much. Hope you have a great day.